The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to the November 2018 Pre-Hospital Care Research Forum Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Megan Corey, and I'm joined by Dr. Tony Fernandez and Dr. Bill Toon, and today we will review the article entitled Decreased Time from 911 Call to PCI Among Patients Experiencing STEMI Results in a Decreased One-Year Mortality. This article is published in the most recent edition of Pre-Hospital Emergency Care. We also have the study author, Dr. Jonathan Studnek. So thank you for joining us, Dr. Studnek, here to help us understand the research and its implications. Now, as usual, this review is paired with an article written by columnist Dr. Tony Fernandez in EMS World called the TRIP Report, Turning Research into Practice. We encourage listeners to check out this article at emsworld.com under the category of Education and Training. So thank you all for joining us today. So let's begin, and we want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we'll bring those into the conversation as we go. Special shout out, we want to welcome Creighton, who is here with their paramedic class. Thank you so much for joining us and for bringing research to your paramedic students. We want to ask anybody else out there who happens to be with their paramedic students, or if you're a paramedic student yourself and you're just learning about research, or an educator, or maybe you're working in the field and you're here to learn about research, feel free to give us a shout on the panel in the right of your screen in the questions area. Let us know you're out there. Okay, a little bit of background. The standard of care for STEMI for more than about 30 years has been fibrinolysis, but within the past 15 years, we know that primary PCI has become more readily available in North America, and it's also shown to maybe have some modest improvements in outcomes as compared to fibrinolysis. Now, one of the issues in STEMI systems of care is the lack of availability and the time delay to PCI. So efficiency of STEMI systems is measured using a variety of time intervals, and it tends to focus on time to reperfusion. And that surrogate of time to reperfusion is the familiar door to balloon time. But that only takes into account the time at the hospital, from the hospital arrival to the intervention. The authors of this paper cite a recent publication in the New England Journal of Medicine that shows a reduction in the median door to balloon time of about 15 minutes was not really associated with a decrease in in-hospital mortality. So this suggests that pre-hospital time interval could be more influential in this total ischemic time. Now, pre-hospital time intervals, as we all know, include a variety of measures. That's 911 to arrival, first medical contact, which is a really tough one to get, transport intervals like extrication from the scene to the ambulance, and then from the ambulance to the hospital. Triage time, maybe that's not a pre-hospital time interval, but, how long do you park it at triage, I would say, is part of the time that you've spent with your patient, and then time to PCI. So just the overlapping time since you're still with the medics on the ambulance gurney. But the authors identify that there's a gap in the research, and we've talked about this on this broadcast, that's what we do. We look at what's out there, what's important, and then we say, but there's a gap, and that gap is that there's been minimal research on the effect of the pre-hospital times on STEMI patient outcomes, in particular survival to 1 year post-STEMI event. So the objective of this study was to ask the question, does the pre-hospital time interval, meaning the 911 call pickup, so this is defined as when the call is actually picked up at the 911 dispatch center to the point of PCI intervention. And we'll talk to Dr. Studnek about that, how to define that, when that actually begins. Does that time interval variation affect mortality at 1 year post-STEMI event? Their hypothesis, of course, would be as the time interval decreases, then so does the 1 year mortality. So Dr. Fernandez, let me bring you in here before we bring the author in and can you help us with the methods of this study? So we've got this question, now let's say we want to do this research. So how then do you go about saying, okay, this is how I'm going to get at this question?
Yeah, absolutely. So, what Dr. Studnek was able to do is largely because they have such a well-established and mature STEMI system of care in Mecklenburg County. They have a STEMI registry, and they were able to link pre-hospital data with in-hospital data, and then they also took the extra step of using data from the Office of Vital Statistics to verify patient death. So they have a really robust data set that they were able to use to do this retrospective study. They looked at data from 2008 to 2014, and they were really able to dive in and do some sophisticated and rigorous statistical analyses to address their study objective and test their hypothesis. Dr. Studnek, maybe you can tell us a little bit about how you were able to link data, and a lot of researchers, they have such a hard time obtaining data. Maybe you can give us an idea of how that was done for this study.
Happy to do that. Thank you very much. And I'd like to thank everybody for having us on today to talk about this paper. We appreciate the opportunity to talk about how we did this research and what we think the results might be for EMS and for care of these types of patients in general. Really, as Dr. Fernandez was stating, the ability to do this type of research really comes down to the fact that we have a system in place already that allows for the free flow of information and data among the EMS system and the healthcare organizations within our community. What's really nice about Mecklenburg County is we have one primary EMS agency that's responsible for the ALS care and treatment of all of our patients, and we have two healthcare systems, Novant Healthcare and Atrium Healthcare. And while those two healthcare systems are competitors when it comes to the EMS agency, they are joint partners with Mecklenburg County in operating the healthcare system. And so as being joint partners, they have a vested interest in understanding how the EMS system is performing, and then on top of that, what we can do as healthcare providers in general to improve the care that the patients within our community receive. And so because that is the case, we are able to form partnerships with both of these healthcare organizations and extract data out of multiple data systems in order to do this type of research. And so we have all of the pre-hospital data within one EMS agency, which makes things very convenient for us. And then we only have to go to two hospital systems, both who are invested in the EMS agency, to be able to receive data from. And so it really narrows our point of contact to three systems in order to get pre-hospital to discharge data. And that is great for us, great to be able to do research, and something that is relatively unique within EMS, where if you go to other systems, you may have more than one ALS EMS system working in a county. You might have 7 or 8 competing hospital systems, all of which you have to get data use agreements from or file multiple institutional review board applications for. And in our system, we only have those two healthcare systems and us. And so pairing up that data and doing that matching is much simpler because of the way the system is structured.
That's just great. Dr. Studnek, can you take just a minute before we move on and just kind of introduce yourself as to, which system you belong to, how you came to be involved in research?
Yes. So, thanks for that opportunity. I've been in Mecklenburg County, the Charlotte system, since 2008, coming up on 10 years now. Currently, I'm a deputy director for Mecklenburg EMS Agency, which, as I said, the primary EMS agency here in Charlotte. My current responsibilities include overseeing the operations of Mecklenburg EMS Agency, so direct field provision, and the communication center. I'm also the lead clinical researcher and oversee a very small small but mighty clinical research team based out of the EMS agency, and then through a series of collaborative agreements, partner with researchers at Novant and Atrium Healthcare.
That's great. And you're widely published. I know we've looked at other publications that from the past. So, I'm sorry, Tony, did you want to continue with describing the study with together with Dr. Studnek?
Yeah, absolutely.
Before you jump on, Dr. Studnek, I think you need to mention where you got your educational background from, because that's very inspiring for other future researchers.
Yeah, so thanks. I'll do that real quickly. So I was and still am a paramedic. I have a North Carolina certification, national registration as a paramedic. Received that initial education along with a bachelor's degree in emergency medical services at the University of New Mexico in Albuquerque, New Mexico. Went to the EMS Academy out there. I think I heard we had some New Mexico folks on the call while we were doing our prep. Then after that, I did the EMS Research Fellowship at the National Registry of EMTs in Columbus, Ohio. Went to Ohio State University and there achieved a master's in epidemiology and a PhD in epidemiology as well.
And that has been a tremendously successful program too.
And I think was actually the first to complete that program.
Yep, and I think it's important that people know about that program.
Yes.
As long as the registry is doing it, if they're serious, it's a great way to learn and get into this, and also have your education paid for.
Absolutely, I'd recommend anyone out there who's listening that is interested in a long-term career in EMS that considers research to be a vital piece of what we do and how we advance our profession, to consider how they're going to advance their education after they're done with their paramedic training. And you can go and pursue a PhD, or you can look at many other options to advance your education and still be intimately involved in expanding the knowledge of our profession. And I would encourage anybody out there listening to look at the opportunities. The registry fellowship is a fantastic one. It served me very well. And there are other opportunities out there as well that will meet your need or the needs of others.
Well, that's great. And we just got word that Creighton Paramedic School has just started their cardio chapter. So this is a great entree into their subject matter. So why don't we continue with the actual study itself now too? So why don't, Tony, you want to carry us through what we were looking at?
Yeah, absolutely. So Dr. Studnek was, as I said earlier, they were able to use data from March of 2008 to May of 2014. And their study population, they specifically looked at patients who presented with acute STEMI, and this was identified by a pre-hospital EKG. They were adult patients. They only included adults. They had to be at least 18 years of age, that were transported to a PCI center within Mecklenburg County, and that met the local protocols for pre-hospital cardiac catheterization lab activation. They excluded patients if they were initially transported to a hospital that didn't perform PCI and then subsequently transferred to a PCI center. If they met the STEMI criteria after being resuscitated from cardiac arrest, or if they were deemed not to actually be a STEMI patient when they got to the hospital. So that was their study population. And again, their primary outcome of interest was mortality at 1 year following PCI. And they also looked at a secondary outcome, which was really interesting, was mortality after 1 month.
Mm-hmm.
So that they didn't just look at long-term, but they looked at short-term survival, which I thought was a really interesting part of the paper. And the way that they did this was really novel. Dr. Studnek and his team, they verified survival, not just using their registry and their data linkage, but they took the extra step of obtaining data from local and national vital statistics records, and that's not an easy task. That takes some work. And Dr. Studnek, maybe you can give us an idea of one, how you thought to do that, because I thought that was a great idea, and two, some of the logistics in going about obtaining and utilizing those data.
Yes. So using vital statistics is actually, they have a really good web interface. It's time consuming, and you'll see that our second to last author, Dr. Patrick Jackson, was a resident while we were doing this work, and so the search of vital statistics records was quite easy for me because we had the resident do it.
Excellent.
Yeah, it's always good to use your resources. However, we knew early on that to really be to limit bias in the study, we had to do a really honest assessment of mortality, and we couldn't have this theory that we can talk about a little bit more in the limitations of having in a longitudinal study like this, even retrospectively, this concept of censoring, where you don't get information on a patient and then make assumptions about that patient. And so in order to make our assumptions as valid as possible that a patient was still alive, using the National Death Certificate Registry was a must, because just looking at local records, you leave a whole bunch of patients who are going to move out of the city, move out of the state, have something else happen to them where we're going to lose them in the healthcare record. And so the vital statistics, we started using their web interface, realized that, yeah, it's time consuming, but we had the resources with an interested resident to do the work. And then we went and tackled that. And I think it really strengthens your assessment of mortality when you can use multiple sources as opposed to just what is locally available to you.
Yeah, I absolutely agree with that. That was really strong work. And I just want to go over your how you define survival, because this was again, this was a pretty in-depth definition here. So survival was defined by a documented follow-up visit or paramedic contact at or beyond 1 year of the PCI. If the patient didn't have a documented follow-up, vital statistics was searched for a copy of the death certificate. Individuals with no hospital record post-PCI and no death certificate were classified as surviving. So they really, you really took a lot of steps to make sure that if they were survivors, they were, they didn't classify folks who potentially survived as having died. So again, and please.
Oh, and I think that last sentence in the methods is really the part where it really kind of shocked us while we were doing the research. There weren't many patients, but we assumed, oh, you had a STEMI, you had a CAS, of course you're going to visit the doctor, a year after your procedure. But there were patients that didn't have any recorded physician visit, and the assumption that they just moved out of town or left, we couldn't make that assumption. We were like, man, who are these people that had a STEMI and then disappeared? And that's a whole other research question. And looking at vital statistics, they didn't die, but within a year of having a heart attack, very severe heart attack, they were no longer with us. And I thought that was interesting.
No doubt, absolutely. So let's talk about some of your analysis. The main independent variable was the 911 call to PCI, and again, being able to link your data throughout the continuum of care, that's such an advantage to be able to do this. And it almost seems too intuitive to use this time metric. It seems like we've been missing something, not doing this in the past. Did you come up with this time interval I know you said you said in your introduction that you did some research and you cited some literature on it, but what made you decide that this was the time interval to assess mortality?
Well, before I came to Charlotte, Mecklenburg County, the STEMI system of care that we're studying was present and very high functioning already, and the cardiology groups that were present in the community, along with the EMS agencies at that time, had already decided on this as a time interval that they cared about, 911 phone pickup to PCI. And so they've been operating this, what we call a process measure, for several years prior to my engagement in the system. And then shortly after my arrival, we did a joint study looking at the subcomponents of that time interval and how to achieve speedy PCI from phone pickup to PCI. And we published those results in circulation. We got some really good feedback and review from that paper. And we've been, kind of in small steps, pushing time measurement for STEMI to be phone pickup. Because really what you want to do is get as close to symptom onset as possible. And we know that collecting symptom onset from a patient is difficult. It's hard to ascertain, may not be readily available in EMS charts. But 911 phone call as a proxy for symptom onset is a very well time-stamped data point and as close to onset time as we can get. And I think from all of that being said, I think it's a wonderful measure that links together the system components of the pre-hospital interaction with patients through the hospital interaction with patients.
I want to jump in there, Tony, before you do
Please.
something again. And I think one of the things that I picked up on, and I don't want it lost on the audience, is the synchronization of time by the atomic clock. And I think many people don't appreciate that. And again, it changes over time, but some PSAP centers, depending on the system that you're in, don't do that kind of synchronization. And then every device within the system doesn't do that kind of synchronization, including the hospital. We were amazed that when I was working in Kansas, that our dispatch center for fire and EMS synced its servers and everything to the atomic clock, but many of the primary PSAP points that were answered by police departments had no such thing built into their thing. So it made it even very hard for us when we were trying to look at what amount of time was lost between primary PSAP and secondary PSAP when we were looking at time intervals. So I give you kudos for mentioning that, but also the work that's involved in trying to get that level of synchronization.
Thank you. And a lot of that work occurred many years ago when they were setting up the system of care, and they had a great deal of foresight to understand how important time is as a measure here.
Great.
So we'll go back into how some of this data set, and this is again a really robust data set. Dr. Studnek was able to not just look at time, this time interval and its impact on mortality in a vacuum, but because of this robust data set, he was able to control for a whole bunch of really important variables that you can actually see in Table 1 on the screen right now. So he was able to control for age, sex, initial blood pressure, presence of cardiogenic shock, and prior history of MI, as well as a risk level. And I thought this was really novel as well. They used a combined measure of risk level, which was actually they defined a patient as high risk if they were at least 70 years old, presenting in cardiogenic shock, had initial blood pressure of less than 100 millimeters of mercury, or had a prior history of MI. As you can see, these are elements that come from both the pre-hospital patient care record as well as the in-hospital record to make this composite measure. And Dr. Studnek, this is also something that I think was one of the highlights of your paper. Can you talk about how you came to the decision to come up with this risk measure?
Yeah, and so this was a consensus measure that we developed between our co-authors. And so our co-authors include two of the lead cardiologists at both healthcare systems and our system medical director. And so we had conversation about how you would classify risk in these types of patients. And we did some literature review to look at risk levels. There are many ways to classify risk for patients who are having a STEMI, and we developed this criteria or determined this criteria based on the consensus of our two expert members on the research team in collaboration with our medical director.
A quick question: you have two categories? You have cardiogenic shock and you have prior MI, but then in risk level you combine them. Was there a reason to tease each one of those out?
We were looking to increase the sample size in the positive and negative cell and the yes/no cell. If you look at table 1, we actually had very few people present in cardiogenic shock. There were only 20 patients. And we had 130, about a quarter of the group had a prior MI, and about a fifth of the group had a low blood pressure. And we wanted something that really said that demonstrated, without getting too complicated in the math, some intermingling of effects of these symptoms or past history. And so we created that risk level. An alternate way we could have done it was, and I think Tony's going to talk about the model in a little bit, was we could have done interaction terms between cardiogenic shock, blood pressure, and prior MI. And that gets really messy and hard to explain. And so we decided to categorize it early in the design of the study instead.
Okay. We have a lot of questions coming in. Some of them relate to the discussion section, so I'm going to hold off on a few of those. But one from Jamie Kennel comes in about the question about missing data, saying missing data is always a challenge. How are missing data managed? And I would add to that, what kind of things did you notice? I mean, if an age was missing, then we miss out a high risk versus low risk population. How do you handle when there's missing data?
So fortunately in this study, what we looked at from a variable perspective, we didn't have missing data. And so we were able to validate from two sources every variable. So if age wasn't captured in the pre-hospital record, it was definitely captured in the hospital record. Cardiogenic shock, you could look at in both places. If there was an initial blood pressure reported in the pre-hospital setting, then what was the first blood pressure upon ED arrival? And so we were able to double check every variable or look in two places for every variable to make sure we had a complete set. And that was one of the things that made this study really attractive, is that we knew outside of mortality, we were going to have a very, very low incidence of missing data.
Great.
And in fact, I'm looking through it and I don't, I'm rereading my own paper. And I don't think we had missing data at all in the set, which is good.
Great. So this is what happens when you publish a lot. You have to remind yourself, which one of my papers is this? All right, Tony, you want to carry us into the next section
Absolutely.
of this? I think we're on figure 1.
Yeah, and you're not having missing data. That is such a such a benefit to doing a study like this. So, and that leads really well into how the data analysis was performed. So Dr. Studnek used multivariable logistic regression to build a model, and essentially what that model did was look at his primary independent variable of interest and see its impact on the outcome, which was mortality, in the presence of these other independent variables, so age. So again, he wasn't looking at this time interval in a vacuum. He made sure he was accounting for everything else in the model, or everything else that could be collected. And one thing I'd like to talk about, we always have to get into somewhat of a statistical discussion. In building a model, you really have to be careful with how you build it and what elements you put in or what variables you put in what order, and you have to do some investigation on the independent variables impact on each other. And I'd like to talk to Dr. Studnek a little bit about, if you can talk to us about how you built your model, and particularly how you handled modeling the risk level in the presence of the other variables that made up that composite measure.
Yeah, so let's get a little wonky in statistics for a second. Take a drink of coffee if you're listening in, so you don't pass out on us here. But the model for this paper actually was pretty simple. We had a few relatively independent variables, and we had a continuous outcome variable. And actually having a continuous outcome variable makes the modeling a little bit easier. And over time, I've developed, and I think everybody who works in epidemiology, does modeling, does statistics, develops their own method of modeling. It's as much science as it is art. You have to have some good references, which I do put into the paper about where I derive my theories for how I'm going to build a model. But to me, a model like this, really what's important is that I have an independent variable that I care very much about, and that's that time from 911 phone pickup to PCI. And so what I really want to know is, how does every other independent variable affect or disrupt that primary independent variable? Does it cause a change, a significant change in the result I would report if I include a different variable or not? And so you build a model, you put one variable in, your main independent variable, and then you do a series of tests with all of your independent variables to see, does my outcome change? And does it change by a level that I think is significant? And what I choose is 10%. So if I see an odds ratio with my main independent variable change by more than 10% when I put another independent variable in the model, then I say, hey, that's a big impact. If I don't include that, then I'm missing a piece of the puzzle. And then as for the risk level and the components that make it up, like I said, we could have done this two ways. We could have looked at interaction terms or effect modification between those variables, or built this composite. And what we did was we evaluated each independent variable by itself. Then we evaluated it with the 911 to PCI time variable to see how that changed our outcome or odds ratios. Then we looked just at risk level, and then we modeled risk level with cardiogenic shock and without. And it's a kind of a painstaking process of doing many, many model runs and looking at your data and trying to suss out what's the story your data is trying to tell you. Do you see anything that's concerning? So do your odds ratios change dramatically? Do they move in a different direction? And you might then learn that, hey, I've got a problem in here that I've got to go figure out in the data to go solve. And in this case, what we found out was that the cardiogenic shock and initial blood pressure were not terribly predictive on their own, and that risk level was a little bit better. It was significant in the univariate or unadjusted analysis. And so we felt pretty good about using the composite measure as opposed to the 3 individual measures to try to determine what we had going on in our population. And
now,
so
Creighton,
really, go ahead.
I was just going to say, well, I'm sorry to interrupt your thought there.
No.
Creighton students would like to know about these, the outliers here, and reporting the outliers in this figure, and how do you account for these as it shows the higher limits of time to PCI could still survive 1 year post MI?
Yeah, so the box plot is in figure 1 is really just a very descriptive measure. So there's no modeling within the box plot. Mm-hmm. And all it does is just tell you what the truth of your data are. And what we find is that, the whiskers, so that 2 horizontal lines on the top and the bottom, and everything in between is 75% of the data, represents 75% of the data in your data set. And then those individual dots up there are what's left over. And we see a little bit higher variability in the group that survives that 1 year. And so what that says to me is just that, is that we have a mean or a median that's lower, and it's significantly mm-hmm. lower. And we have a little bit more variability in these survivors. And, I would expect that. I mean, we're building a model on survival here, which is, mortality is a really big concept. And I don't think any one piece of a system can be credited or held accountable for all of mortality. So you would expect that your model or your data won't explain 100% of why someone survived or why someone died. And those outlier data points right there just show that, yeah, even in the presence of pretty strong results, there are some people that still managed to survive that had really extended times. And there was mm-hmm. something else that explains that result. Could have just been their genetic makeup, could have been some more type of advanced care in the hospital. We don't know. But we do know that any model we build isn't ever going to explain 100% of the data in it. And that box and whisker plot just shows that.
Well, let's move to the next thing then, since you mentioned other variables. Table 2 shows the crude and adjusted odds ratios for survival at 1 year by 911 call to intervention and other independent variables. So help us walk through what we're looking at here.
Yeah, so this really is that modeling that we were talking about. And so moving from left to right, you just have first the descriptive variables of the independent variables we were looking at by whether or not an individual survived or not. And we see, and the real take-home message here is that individuals who survived at 1 year, their average time to PCI was 80 minutes, 80.8 minutes. And that's compared to an average PCI time of 93.9, almost 94 minutes. So 13-minute difference in time to PCI among those survivors and non-survivors. And when you look at the 95% confidence intervals, for the sample size we have, they're relatively narrow and they don't overlap. And that to me indicates that we've got a real difference here in survivors compared to not survivors. And that time is important. When you move over one column, you see our unadjusted odds ratio, and that's really the meat of our results. And we see the unadjusted and the adjusted odds ratio doesn't change, which really, to me, strengthens the fact that this is very close to what we would think of as true with very narrow confidence intervals, and that your survival decreases 0.97 for every minute increase in PCI time, or said a simpler way, every minute delay in PCI time reduces survival by 3%, or decreases the odds of survival by 3%. So it doesn't decrease survival, it decreases the odds of survival, which is important nuance, because you're thinking about this from a population perspective, not a person perspective. And that's nuance in statistics that's important to remember. So it decreases your odds of survival by 3%. And age was a significant confounder in the model, and it was the only one. And it had, and though it was significant from a p-value perspective, it didn't really change our adjusted odds ratio significantly. And so we can say, you know, at most levels of age, and irrespective of gender or their risk, if you don't receive every 1 minute increase in PCI time, you're going to have a 3% decrease in odds of survival, which I think is pretty meaningful when you think about it from a population perspective.
Yeah, and Greg Clyburn says from one observation from 30,000 feet is the way he puts it. This study reminds us again that the familiar hospital focus measures such as door-to-balloon time don't tell the story of a system of care. And there's so much food for thought here in the integration of EMS engagement beyond the patient transfer, data exchange, and more. Very true. And also some comments from Creighton related to this. You know, with these results, it reported data in the patient's interest to get to the PCI lab as soon as possible. With this in mind, why are there still barriers for EMS to transport right to the PCI lab with a STEMI and bypass the ER following cath lab activation from the field? So a number of things related to, you know, what the meaning of this study. And I think we can get into that, but we should probably finish with the secondary outcome measure too, which was in table 3. Which is up right now on the screen.
And so table 3, you see a very similar, very similar data. And the reason we looked at 1 month survival was to do what you would call, it's kind of a sensitivity analysis on our data to see if we had really, really different results at different periods of time. Because if survival at 1 month was very, very high or very, very low, and it was the opposite result at survival to 1 year, it would give us concerns about the validity of our data, and other issues that might be going on within the care of this person or this population. And so we wanted to look at both time periods to give us a good sense that, hey, you know, this measure is consistent over time, and if you look, the adjusted odds ratios are very similar, confidence intervals very minutely, and this gave us a high degree of confidence that the results that we were reporting were valid for this data set.
Tony, do you have any input on you know, how we are looking at all of this data and evaluating? I think we're getting at I think the bottom line is, and again for Creighton and for other paramedic students out there, is when you develop a research project and you develop a good research question, then you have to look to see, does your methodology fit, you know, appropriately measure your research question and evaluate it, and then is your analysis meeting that? So are there any points in this and in this study where you felt like, well, there were some things that we missed or would have liked to have done differently?
So I think that what was great about this study was just the access that they had to data and throughout the continuum of care. This would be very hard to do for a system who is not as integrated and frankly who is not as open to sharing data. With any model, you can always look for or say that, you know, it would have been great to have X, Y, and Z additional variables that you may or may not have access to. You can never really build a model with every variable that might impact, in this case, mortality. So you can always say that you'd like to have different variables. One thing that we look for a lot, that this study was actually able to do, was history. We miss medical history in a lot of pre-hospital research, just because we don't get that typically in the field. But this study was able to include history, particularly of prior MIs. So I think that in terms of running this model, this is probably as good as you're going to get. We do want to remember that this is a retrospective study, and we talk about a lot level of evidence, right? But we're never actually going to be able to do a randomized trial where we give some patients, we get some patients from 911 call to PCI in 94 minutes and some in 80 minutes. There's no IRB in the world who's going to approve that study. So I think that in terms of level of evidence, this is pretty high, and this is the model was done really well.
Yeah, and I think we always have to look back too at the exclusions and say, okay, what does this study not look at? And we don't look at non-hospital or non-cardiac cath lab hospitals, of course, transfers that go from those hospitals, the ROSC STEMIs, and false positives. But that asks a different question, that we're looking at a specific subset of confirmed STEMI patients. So the other question then would be, that's a separate study, is, what are the misses? And you might already have an idea of that in this system, because you have such a rigorous data set as to, how often do we miss these, and why do we miss them, and why do they go from to non-cardiac cath lab hospitals, and and then ROSC STEMI is a whole different beast. So we always look back and say, did we miss anybody in it? But related to the question, I don't think so. I think this was related to the research question. This is exactly what we were looking at, where those who actually are already STEMI activated and identified. Do you have a sense of the false positive pre-hospital activations?
Yeah, we've done a fair amount of research on this data set, and we published a paper probably 3 years ago that did a pretty comprehensive look at what our false positive activation rate looked like, and did a really in-depth analysis of how you define a false positive activation, because a very peripheral definition would be, well, anybody that didn't get PCI. Well, there's many reasons why a person doesn't receive a PCI, and they may be presenting with a STEMI. If you have a 95-year-old patient who's bedridden, is near end of life, and has a STEMI, are we really going to cast that person? And so is that a false activation on the EMS side? I would say no. I would say EMS's job is to identify what is occurring, and what we see occurring is a STEMI, and then the physicians need to apply some rigor to their decision about how they're going to intervene on that patient, and then be able to have a conversation with family and understand what's the best course of care for this individual patient. And so I don't know that an EMS system should be dinged, such as it is, for recognizing a STEMI in a patient that may not have an appropriate course of care via PCI. And there's a lot of other pieces that go into defining who is and who is not STEMI appropriate. There's the obvious misses where you look at the ECG and you say, well, we just missed that. That wasn't there was no elevation in that 12 lead, and we just misinterpreted it. And so that occurs. The heart is a dynamic muscle, as is everything else in the body, and sometimes what you see changes, right? And so you can see elevation in the pre-hospital setting, and it doesn't show up on the ECG in the hospital. And so you have to rectify how are you going to manage those types of patients. And we've done some collaborative work with the state STEMI registry here in North Carolina, and then some individual work, and we've published those results in some other papers looking at false activations, false positives, and that type of work.
We have a lot of comments coming in from Creighton that relate to things like what is done in the field. And then another person has just posted something about kind of the care that occurs, or the time interval, splitting the time intervals into smaller segments out into the field. But I think, again, this is another thing about evaluating research. This is about a time interval that we're saying probably would make more sense than just what we've had in the past, which is splitting hairs over whether or not we've, is the medical arrival at the patient's side time, how do we measure it, and do we get it from charts, and it's always inaccurate, and all this stuff. Rather than having that, we say, look at the real time. The real time, according to the patient's heart, is the time that the symptom onsets begin, and the surrogate for that here, the proxy, is the 911 call. And then to the PCI actual intervention, and so that's what we were actually looking at. But some discussion items, and maybe Bill, you want to join in on this part too. That there's questions about, again, earlier I had said that Creighton had asked about, why do we still, if we have these, we know it's important, we know this time is important now, and now with this we really know. So how do we get by some of these barriers about going EMS transport right to the PCI lab, bypassing the ER? And what about things like cardiac lab biomarkers in the field, and questions of speed of flight, getting a helicopter and that kind of thing? Where does that all fit in here?
So, do you know what I think that one of the beauties that this paper brings out is it talks about a total system of care.
Yes.
And I think that all of those questions they ask get back to, are you in a system of care? So I've worked in locations, a system about half the size as Mecklenburg, and we were very fortunate that we physically had a seat at all of the STEMI processes that went on at all the hospitals. And we had, at the time I was there, 7 hospitals, and the uniqueness there. But at least if you're part of trying to resolve the issue and hear some of the stuff, you begin to say, well, okay, it's interesting the hospital's having these problems with their issues, and time is a huge thing in there. There is no synchronization of time in the hospitals that I worked in. And I still think synchronization of timepieces is a really critical thing to make sure we're truly equally measuring. But it's a system of care. Are you there at the table? Are you trying to address the issues? And you take each one at a time, and when it's resolved, it's truly the beauty of a continuous quality improvement process. And in the end result, I have seen that systems of care, and I don't care whether we're talking STEMI or stroke, have a really powerful and positive impact versus places that don't. And there's no question, rural and frontier medicine is a unique body of information out there. And I don't know, we can't apply things that take place in comparison to those more urban areas. They need a unique thing. They need a system that looks at, okay, they go to the critical access hospital, that maybe therapeutic, some kind of thrombolytic therapy is established, transport to the appropriate facility. They're an entirely different beast that, again, needs a system look at. And to answer the question about, I think the important one is from the field into the, directly into the cath lab, is really still a system, is relating to an entire system process. And I think that when you can demonstrate time savings like this program has done here and what they've achieved in your system, you'll begin to break down those barriers. But that takes, I don't think people appreciate the amount of time that it takes to mature a system. So you're not looking at something that's going to happen in months. You need to be looking at being comfortable with something that's going to take years to develop to this level of sophistication.
Yeah, and not just the actual, when we talk about systems of care, I think a lot of us think of the actual hospitals, the ambulance providers, the treatments, the, radio communications. But this, I think, shows, and I think Tony alluded to it earlier, the power of and the importance of having the databases and the ability to actually pull in reliable sources of data because without that, we don't even really know, whether or not this is working. So how do you get there? How, Tony and Dr. Studnek, how do you get there? How does a system go and become a Mecklenburg, a North Carolina, where we're just seeing volumes of really good quality data and research coming out of their data sets? How do we do this?
So I think it's really about collaboration, and Dr. Studnek, he speaks to this in his discussion sections really well. So I'm gonna actually punt this one to Dr. Studnek because I think the way he described it, I really can't do a better job. So please, Dr. Studnek.
Yeah, so thanks for that. And I also thank the editors at PEC because the third paragraph in our paper, they let us get up on a soapbox a little bit, which I think is kind of important. To Bill's point earlier, one thing I want to mention is the system of care in Mecklenburg County. It's specifically related to STEMI, is at least 15 years old. Probably started working on it 20 years ago. And you might think, oh, you started working on it 20 years ago. You're writing papers, things are great. And I want the listeners to know that this is a fight every day. Every month, every quarter, we review these data. We get together with our cardiology partners and hospital administrators. We have difficult conversations about what is going right, what is going wrong in our system, and we come up with ways to fix it. And it's hard and it's complicated. And once you build it, it doesn't just stay. You got to keep fighting. And the folks here that run the hospital systems and the EMS agency are willing to engage in that in STEMI and in other systems of care, and you have to have that willingness. Systems who want to achieve their mission of providing good care to patients, they need to engage with their hospital systems, and they need to start measuring meaningful data. For such a long period of time, I've heard, well, the hospitals won't let us measure this. Well, we can't get outcome data. Well, okay. Start with yourself. What can you measure in your system that's meaningful and that might impact care? And go look in the literature and you'll go find it and start measuring your performance. Once you have data, you can start bringing that to hospital systems and say, here's what we're seeing, but our picture is incomplete. Help us fill out that picture. And if you find hospital systems that want to care for their patients, they'll want to be able to use your data to show that they as a system are providing good care. So start with yourself. What can you measure internally and bring that information to the hospital systems, and then start having a conversation that centers around data, centers around a system, and centers around how you can perform. If we just continue kind of on this woe is, oh, I can't share here, or this is difficult here, then you're right. We won't be able to build a system. But somebody has to start. I would encourage you to start asking those questions. What can we access internally? What can we use? How can we start developing data, best practices, measures based off the literature and start there? Otherwise, we'll continue kind of in this rut that we see nationally where we fight against each other in an ability to collect data. It's not easy, and it's never going to be easy, but you got to commit to doing that type of work in order to advance the science of our profession.
That's fantastic. What a great way to wrap this up. We only have 1 minute left, and we want to be respectful of all our listeners' time and of Dr. Studnek's time. And thank you so much for joining us with great points you've made. And Tony, it's always great to have you help us with the stats. Bill Toon, Tony, you got any final comments?
Thank you, John. I have been following your career and the research that you develop, and you're certainly contributing. And I am very jealous and envious at times, but I also know that it's an immense amount of work to do what you've done and achieve what you've done, and to do it on top of all of your operational responsibilities is pretty amazing. But thank you for your contributions to the profession.
Thank you.
Tony?
I appreciate that.
Tony, any final comments?
Yeah, I just want to, again, congratulate Dr. Studnek and his co-authors. I think this is important work. I think it's well done, well written. And I just want to congratulate him and say, keep up the good work. This is great.
Well, great. And thank you very much, everyone, for joining us. We want to remind you that we have an education research podcast that's held on the fourth Friday of the month. You can join us for our education research podcast later this month on Friday, November 23rd at 10 a.m. Pacific and noon Central Time, when we're going to discuss research on experiential education of paramedic students with geriatric patients and the effect on interpersonal communication skills. And we'll be back here with our clinical podcast on Monday, December 10th, when we discuss research on EMS screening protocols, allowing field providers to medically clear psychiatric patients in the field, bypassing emergency departments for specialty psychiatric care centers. So we welcome you all to join us next time, and thank you again, Dr. Studnek, for joining us today. We'll see you next month.